mellitus. So I will be comparing the clinical characteristics of type 1 diabetes and type 2 diabetes. As we can see in this figure, in a healthy individual, insulin is secreted from the beta cells of the pancreas, which acts on the insulin receptors on the cell and mediate glucose uptake by the cells. So glucose uptake or utilization of the cells is mediated by insulin action. Diabetes is a chronic condition which is caused by absolute lack of insulin or relative lack of insulin due to impaired insulin secretion. It can also occur due to impaired insulin action caused by insulin resistance. So the insulin levels may be normal or elevated, but the tissues fail to respond to the actions of insulin. Diabetes is caused by abnormalities in insulin secretion or insulin action or both. The clinical characteristics of diabetes are asymptomatic glucose intolerance causing hyperglycemia and abnormalities in lipid and protein metabolism. In long term, these metabolic abnormalities can lead to complications such as cardiovascular disease, nephropathy, neuropathy, retinopathy, and it can also lead to cancer. Diabetes is classified into type 1 diabetes and type 2 diabetes mellitus. So let's compare the clinical characteristics of type 1 diabetes and type 2 diabetes mellitus. Type 1 diabetes mellitus is also known as insulin dependent diabetes mellitus because there is complete beta cell deficiency and the patients are dependent on insulin for treatment. It is also known as juvenile onset diabetes mellitus because the age of onset is early. It occurs in younger individuals less than 30 years of age and peaks at 12 to 16 years of age. Therefore, it occurs in younger individuals, it starts early and it is known as juvenile onset diabetes mellitus. Type 2 diabetes mellitus on the other hand is known as non-insulin dependent diabetes mellitus because these patients are not dependent on insulin, they can be treated with oral anti-diabetic medications. It is also known as adult onset diabetes mellitus because this type of diabetes mellitus develops after 40 years of age and there is increasing prevalence of this type of diabetes in obese children. With respect to percentage of diabetic population, approximately 5 to 10% of the diagnosed diabetic population suffer from type 1 diabetes mellitus, whereas most people who have diabetes have type 2 diabetes mellitus, so it is more common. It occurs in about 90% of the diabetic population. So type 2 diabetes mellitus is more common than type 1 diabetes mellitus and it occurs because of insulin resistance and impaired insulin secretion. With respect to family history of diabetes, type 2 diabetes mellitus have a stronger family history of diabetes compared to type 1 diabetes mellitus. However, there is no association with HLA types. Type 1 diabetes mellitus is due to autoimmune destruction of the pancreatic beta cells. There is strong association with HLA DR3 and DR4 and there is presence of circulating antibodies against insulin and islet cells or beta cells of the pancreas. In type 1 diabetes mellitus, there is autoimmune destruction of pancreatic beta cells and this is triggered by environmental factors such as viruses and toxins in genetically susceptible individuals. So the immune system attacks the pancreatic beta cell causing complete deficiency of beta cells and absolute lack of insulin. There is presence of circulating antibodies. The antibodies against the islet cells, against the beta cells or insulin are present in the circulation and this is an indication of an autoimmune process. So, evidence now exists that the onset of clinical symptoms is preceded by a preclinical period or an asymptomatic period during which the beta cell destruction occurs. So beta cell destruction starts early and occurs gradually over the period of time and at the onset of clinical symptoms there is fasting hyperglycemia and when the patient is diagnosed with fasting hyperglycemia about 80 to 90% of the beta cells are reduced, are destroyed and the patient is left with little or no pancreatic reserve. And over the period of 8 to 10 years, there is complete loss of beta cells and there is absolute insulin deficiency and the patient is dependent on insulin. So initially, these patients present with postprandial hyperglycemia And gradually, as the insulin secretion becomes more compromised, there is progressive fasting hyperglycemia, and during clinical presentation, there is fasting hyperglycemia and elevated glycosylated hemoglobin. So this is how type 1 diabetes progresses over a period of time. Now coming to the clinical symptoms, because of extreme hyperglycemia, there is increased osmolarity of the blood, and this stimulates the thirst center and stimulates the patient to increase the water intake, causing polydipsia. When the blood glucose level exceeds the renal threshold, glucose appears in urine, causing glucosuria, and this causes osmotic diuresis and polyuria, that is increased frequency of urination. These patients also present with weight loss because excessive loss of glucose in urine, excessive loss of calories in urine, and also there is breakdown of lipids and proteins because of increased lipolysis, increased proteolysis due to lack of insulin. There is also polyphagia because of loss of glucose in urine, and the patient has a craving for sugar, has a craving for glucose. Also, there is increased risk of infections because glucose provides nutrition to the growth of microorganisms. Therefore, the patients present with various kinds of infections such as respiratory infections, vaginal infections, dental infections, and other infections. Do remember that ketoacidosis is common in type 1 diabetes mellitus. This is because of absolute lack of insulin. Because of absolute lack of insulin, there is excessive mobilization of free fatty acids into the liver, and these fatty acids are metabolized into ketones, causing ketone body formation and ketonemia. When the excessive ketone bodies appear in urine, this causes ketonuria or the loss of ketone bodies in urine, and eventually ketoacidosis occurs. So ketoacidosis is common in type 1 diabetes mellitus, but it is a rare occurrence in type 2 diabetes mellitus except in circumstances of unusual stressful event. In such patients, ketoacidosis can be life-threatening. It can lead to dehydration, infection. So the patients have to be treated with insulin. So insulin is the main treatment in type 1 diabetes mellitus. Now speaking of the pancreatic function, pathogenesis and clinical presentation of type 2 diabetes mellitus. Unlike type 1 diabetes mellitus, type 2 diabetes mellitus is due to impaired insulin secretion and insulin resistance. As we can see in this figure, insulin is secreted from the pancreatic beta cell, but insulin fails to act on the tissues because the tissues of the cells fail to respond to the actions of insulin because of insulin resistance. So insulin resistance decreases the utilization of glucose by the tissues, causing increased blood glucose level and hyperglycemia. Also, there is increased glucose production by the liver, and this further increases the blood glucose levels, causing extreme hyperglycemia. This increased blood glucose level stimulates the pancreas to secrete insulin, and this increases the levels of insulin. So there is simultaneous increase in the blood glucose level and insulin levels. Although the insulin levels are normal or elevated, the glucose utilization by the tissues is impaired, and this occurs because of insulin resistance. So there is fasting hyperglycemia, the glycosylated hemoglobin levels are elevated, and also there is increased or elevated insulin levels, and there is absence of circulating antibodies. Unlike the clinical presentation of type 1 diabetes and type 2 diabetes mellitus, the symptoms are mild. There is mild polyuria, fatigue, and often the patients are diagnosed on routine physical and dental examination. The patient usually presents with fasting hyperglycemia and elevated glycosylated hemoglobin. Now do remember that in type 2 diabetes mellitus, ketoacidosis is rare because the insulin levels are normal or elevated. So ketoacidosis is rare except in circumstances of unusual stressful event. However, extreme hyperglycemia can increase the osmolarity of the blood, causing hyperosmolar non-ketotic coma, which occurs in type 2 diabetes mellitus. So with respect to treatment, type 2 diabetes mellitus patients can be managed with oral anti-diabetic drugs, and if the patient fails to respond to oral anti-diabetic drugs, he can be treated with insulin. So in this way, type 1 diabetes mellitus can be compared with type 2 diabetes mellitus with respect to its age of onset, obesity, family history, pancreatic function, pathogenesis and clinical presentation. Thank you for watching. If you find my video useful, please like and subscribe to this channel.